so it's just after 7 o'clock. Welcome everybody to the joint First Five and Derbyshire Education Network session tonight. We're very lucky to have with us Jodie Rogers. She's an audiologist from Chesterfield. She's been there quite a few years and she was at Derby before that. And I will let her introduce herself in a moment. As most of you know, I'm Elise Brogan. I'm a GP at Crouch Medical Practice in Derbyshire, and I work for the GP Task Force running these education sessions, and I also do some work for the New to Practice sessions as well. Also with us, we have got Benisha Patel. So I will hand over to Benisha in a moment because, well, she will explain it all, but her company is sponsoring this session for us tonight. So thank you so much for being with us, Benisha.
So hi everybody, thank you so much for allowing me to be here today. My name is Benisha Patel. I'm an account executive for Chiesi. So some of you may have heard me talk on the last one of these sessions. I've done a few, or you might know me from the Derbyshire area, but I work with the Foster range. So just going to talk for the next sort of 10 minutes or so just on our Foster MDA and Foster Nexthaler, which is licensed for your uncontrolled asthma. Obviously it's licensed in COPD as well. So we're just going to touch on what sort of good asthma control looks like. I know there's a few generics sort of come around, and so we just want to touch on, you know, good asthma control, you know, getting the patients on the right devices. We're going to talk a little bit about the benefits of the Nexthaler in particular, which is our dry powder inhaler, and then I'm going to talk a little bit about some work that Chiesi has been doing around sustainability and their new environmentally friendly propellant. So obviously one of the things, or one of the big studies that we're looking at is the 2014 National Review of Asthma Death, which looked at the amount of SABAs and things like that people were prescribed in the year before their death. So one of the main things that they found from that study is that patients were actually prescribed over 6 SABA inhalers, and that was in 2014, and it's crazy that things haven't really changed since then. You know, 3 people a day will still die from an asthma attack, and the reason that I bring that up is because having the right device for the right patient is really, really important. Assessing device technique is really, really important, especially because we have so many different inhalers out there. So I just wanted to sort of draw attention to that. Now, the reason the Foster range could be a great option for patients is because it is actually the only extra fine formulation that's available in 2 different devices. So that means that, you know, whether it's PMDI or the Nexthaler, which is the dry powder inhaler, you only sort of have to remember the drug once, but you have the option of using it in either. So, you know, whether that patient's MDI suitable or dry powder, you can really assess their needs and then decide which inhaler to go for from there. So one of the things that makes the Nexthaler then really, really different is that it has this dose counter on the front. Now that only counts successful inhalations. If anybody does want any placebos or things like that, please do drop a message to me in the chat function, because I can always pop by the surgeries and just drop them off for you. But that dose counter only counts successful inhalations. So if you mess with this, that dose counter won't move. You need to have an inspiratory flow of 35 litres per minute in order to activate the inhaler. That's important because it's relatively low compared to some of the other inhalers out there. And that's also important because once you hit that flow rate, this inhaler makes a clicking noise, and it will only make that clicking noise if you have the correct inspiratory flow. Now, placebos can be a great, you know, training device and training technique for your patients, because you can simply give them a placebo, say, you know, make this clip for me. If they can, that means they can take it correctly. If they can't, they shouldn't be on a dry powder, because 35 litres per minute is relatively really low compared to things like Symbicort and Fabumix and things like that. The other difference is 35 litres per minute gives you 100% of the dose, so it's kind of all or nothing. So you literally can't get it wrong. So I'll show you how to use it now. So you open it, empty your lungs away from the inhaler, and then it's a deep, sharp breath in through the clip, and then hold your breath for about 10 seconds. Hold my breath, close it, counter goes down. If I didn't do that, if I just mess with it, nothing happens. If I don't have enough suck, nothing happens. If I'm on BD dosing, I have to make sure I close it and reset it. So it's really, really easy to use. It's literally foolproof. It's a great, you know, inhaler to get your patients having a go on. Give them a placebo if you're not confident they can use it. But, you know, it's a really, really good device. And again, if anyone has any questions or wants any information, any patient support materials, any education as well for your surgeries, you know, please do let us know, because we run some Chiesi education sessions. They could be on asthma, COPD, things like that. that, just to kind of help you guys out anywhere you need to. And we can run them in a time that's suitable for you. So, you know, I did one today because it was protected learning time, so we can arrange things like that for you. In terms of the sustainability then, so we have got an environmentally friendly propellant coming out in the next sort of 18 months or so. So what that means is our Foster MDI will have the exact same carbon emissions as a Foster Nexthaler. So it'll be 90% reduction in carbon emissions. I know sustainability was really, really important. It was on everyone's agenda last year. I think this year it sort of fizzled out a bit, but it's just good to know, because I know there's a lot of different inhalers claiming carbon neutrality and all things like that, and it's a big hot topic at the minute. So just wanted to make you guys aware of that. You know, you don't need to make changes to these other inhalers, because come 2 years' time, you know, Foster will be out there and be the exact same as the dry powder. Well, I'm sorry that my presentation didn't work and it was a quick whistle stop tour, but I hope that was okay, and I will leave you guys to it to enjoy the rest of your session.
Thank you so much, Benisha.
Thank you.
Thank you. The people who joined, about they had no idea that anything had gone wrong there.
Yeah. Thank you so much, and I'll see you later. Thank you. Bye.
No, thank you so much, Benisha. That's brilliant. So for anyone who's just joined, I'll just mention again, so we've got Jodie Rogers here with us, an audiologist from Chesterfield, with some colleagues. I'll let her introduce herself and her colleagues soon.
Obviously, I will start off by saying thank you so much for opting to join us tonight. I suppose I could say thank you for inviting us, but I think we actually invited ourselves along to your meeting. We've been really keen to try and find a way of engaging with primary care for quite a while, not really sure how to get in there. And so I won't reveal names or why, but I ended up having a patient who was a GP, and I said, right, I've done my bit, now you can give me something. How on earth do I get in there and start some conversation? So that was how we discovered that you had these sessions. So thank you very much for allowing us to come along. As for introductions, as mentioned, my name's Jodie. I'm one of the audiologists from Chesterfield Royal. Also joining me is Debbie Alvey. Debbie is we work really closely together, and I suppose we're the two audiologists that work really closely, mostly with our ENT, and share a lot of the referrals across. So that's where, as we get into why we wanted to do the talk, we sort of pick up most of the questions and queries. Also joining us is Deb Farr. Deb is our service manager for Chesterfield, and John Butler is also on, who is the Derby service manager. So hopefully between us we will be able to answer any questions or any queries that you may have. When we talk about audiology, I have got about the other providers in the area, but in terms of your two main services that cover the entire Derbyshire, that is us guys that work for Chesterfield Royal, and also the team that work at the Royal Derby as well, and we cover the entire region. And it's us guys at Chesterfield that pick up the High Peak as well. So I put that on as contact details. I actually should have asked. I don't know whether you all share and have the slides after or not, but if not, we can always get that information out to you as well. We're going to pick up on the any qualified provider, which is sometimes causing a lot of confusion about what those other services are, but they are of course also part of audiology services, but this is your main two for the area. The reason that we wanted to come along and meet on what I've sort of labelled as the aims of the session is to kind of clarify what we've picked up as sort of concerns, or where we've seen primary care not being too sure what to do with patients. And so we're hoping that by the end of this you'll have a much clearer idea. The aim being, of course, is that we get a much smoother patient journey, because they end up with the right people first time round, and also saving you guys having to pay for multiple referrals because you get it right the first time round. What we've noticed as trends is duplicate referrals, so patients who leave a GP surgery 2 referrals on the same day. Incorrect referrals, and also labelling here, also including the next line down, which is the incorrect use of the any qualified provider scheme. So we're going to clarify what that is about. I also want to mention the other available ENT services that don't have any audiology cover, which again does cause us some concerns and some problems, and again, results in duplicate referrals and numerous referrals you guys having to pay for. I wanted to touch on the management of sudden hearing loss. I know Mr. Kodai, one of our ENT consultants, has been doing some work with primary care, so some of you might already be aware of the changes that have come in about how we manage sudden hearing loss, but I wanted to touch on it as well. And also just talking about the advice given to tinnitus and balance patients. Originally, I got grand plans to go into a great lot of detail about tinnitus and balance, and then I realised that we would be here until midnight. So I hope I've covered enough, but we're also really happy to come back at a future date if you want more detail about real specific conditions. So again, we're always happy to come and provide even more detail or have other conversations other times. We've left the email addresses and we're very happy to keep having conversations with people. So just to clarify the entire coverage that you have in Derbyshire for your audiology, otology patients, you have us at Chesterfield Royal Hospital, so we are responsible for the audiology work. We'll accept referrals from anywhere. We're not picky at all at Chesterfield. We'll have anyone. But we generally will pick up those people from North Derbyshire. And what causes confusion, I think, sometimes is we are also the main audiology provider for the High Peak, but the patients do not have to come to Chesterfield. We come up to the High Peak to see them. So that again seems to cause some confusion. I'm going to go into what any qualified provider all means, but at Chesterfield we are part of the any qualified provider scheme. We are also accepting patients who are non-AQP, as we call them, so people who don't meet the criteria for any qualified provider. We also have them, and of course we also have our ENT service as well. Royal Derby will generally pick up those patients from South Derbyshire. Now John and his team chose not to join the any qualified provider scheme, so they don't accept those patients, but of course they do pick up the non-AQP patients, the patients that don't meet the criteria. They will be seen at Derby Royal, and of course they have their ENT service as well. I really wanted to highlight, because I think it's underutilised, this service that is based out of the Buxton Cottage Hospital. It is Stockport ENT doctors, but they seem to run very, very separate, even though it's the same team. So if a patient letter is written to Stockport, they have to go to Stockport, but if you write to the Buxton Cottage, the person will have a local service and be seen there. They don't seem to cross them over too often from what I've seen, and I kind of don't think that Buxton Cottage is used enough, and they really do have a good service. So I wanted to make you aware of that. In terms of the any qualified provider contract, we are in March. April is round the corner, so maybe there will be a change, but we don't think there's going to be, at least for the next 12 months. So we're not expecting any new providers to join the scheme. At the moment, the any qualified provider scheme is ourselves at Chesterfield Royal, Specsavers, Scrivens, and the outside clinic. So they are your any qualified providers. In terms of the difference of what services are, so audiology, of course, we are managing disorder of the hearing and the balance system. The role of the hospital-based audiology services, so ourselves at Chesterfield and the guys at Derby, we are going to be responsible for diagnosing hearing loss. We support ENT with diagnosis of the complex conditions, and we are responsible for the rehabilitation of routine and complex conditions. And this is where it gets different, and this is where I think it causes confusion. The any qualified provider service is a service that is responsible for diagnosing age-related hearing loss to allow provision of hearing aids and the rehabilitation around it. And that is what the AQP scheme is in place for. I'm going to go into more detail, but again, I just wanted to sort of start off by clarifying the differences in what is available. A service that I felt needed some advertising, because I don't think it's used enough, is Hearing Help UK. Hearing Help UK has the contract from Derbyshire County Council, and it also has some help funding, I believe, from the new board. They have the contract for the provision of environmental equipment, so this might be advice with regards to TV systems, loop systems in people's homes, They don't provide phones anymore, but they can certainly give the advice about phones, doorbells, and access, things like that. They're a really fantastic charity. They are based out of the Amber Valley in Ripley, but they are responsible for the contract for the entire of Derbyshire. And the reason I think, the reason I really want to promote them is two other reasons. They are fantastic at promoting social engagement for people with hearing impairment. We know there's obviously a strong correlation as people get older that they will have a hearing loss. We know that the elderly will struggle more with isolation, and of course having a hearing impairment also impacts on that. And what Hearing Help do is they run social events all over the county. They do a lot out of their Ripley base, but and COVID did hit them with trying to set up a lot of meetings, but they are now back in full force and setting up sort of events all over the county for people to go and join. So if you did have a patient who was struggling and wanted, if you have social prescribers maybe in your practices, it would be something that would be good for them to know about. The other thing that I think is fantastic is they do provide personal amplifiers and they will do it very urgently. So if you have a patient who is struggling desperately with communication, it seems to happen when maybe they get admitted or released from hospital, maybe a sudden admission into a community hospital or a nursing home. Generally in the transport, hearing aids go missing, and then the person, you're struggling to manage a care package. If you contact Hearing Help, they'll get a personal amplifier out to that patient within 24 hours. So that will often help whilst you are trying to get a referral back into the provider, and we will try and get hearing aids back and set up as soon as possible. Obviously, it's not there just to while someone's on a routine waiting list, but if you're really struggling with communication with a patient and it was hindering care, then that is a good way of getting some help out if you use Hearing Help UK, and they are very, very responsive to that. A couple of other things just to be aware of, I think. The Derbyshire Fire and Rescue Service I know they do it anyway for all things, but they do wellbeing checks. Yes, they will come and fit fire alarms, but they also have specialist fire alarms in place for the hearing impaired, because obviously someone with a severe hearing loss may not be able to hear a normal alarm, so they will come and assess for that. They can also They do it with the county council, but they'll also provide paging systems. So if someone has a severe or a profound loss, and it wouldn't be able to hit any alarm that was fitted in the house, then there are specialist systems. So if there was any concerns over wellbeing, yourself, the patient, the family could ask Derbyshire Fire and Rescue Service to come and do a wellbeing check on that person and make sure that they are safe. The other thing, again, I do like to promote this quite a lot when we get a chance, because it doesn't seem well known about, and that is the Access to Work scheme. The Access to Work scheme is a government funded pot of money that patients, people can sell if they have a disability and they are struggling to remain in employment and they need equipment, they need some adaptations, they need support, financial support, they can't sort of get to work anymore and have got to have taxes. There is a really fantastic scheme to allow that person. I appreciate it may be not what you refer in primary care. I know that maybe wouldn't be what you would want to doing, but I think it is important that people know there is that money out there and it's not used enough. So if someone has a disability, they can apply to Access to Work for funding and for help, and they are very accessible. They will do a work-based assessment. We use it particularly where people maybe do have they've got their hearing aids, and I would hope we're fitting the hearing aids well, but obviously sometimes there is a really challenging work environment, and with the best will in the world the hearing aids won't be enough. So we ask them to apply to Access to Work for maybe remote mic systems, so that the person can have improved hearing within their work environment. We've also used it when people maybe work in environments where there's a lot of PPE and they can't actually use the hearing aids we would traditionally provide on the NHS, and so they've then been given specialist hearing aids to work in that system so they can remain safe. So it has a really, really wide scope, and it's well worth being aware of. I didn't think that I could do a talk to you without talking about earwax. So when is it a problem? In audiology, every single day. And that answers that question. I know that regionally, or nationally, should I say, obviously a lot of GPs, a lot of primary care aren't offering earwax removal. It is difficult for us in audiology, and I'm sure it's not a sort of maybe any easier for you guys. Obviously, within NICE guidance, it does state that if the wax is causing a problem, it should be removed. But I think I just really wanted to make you aware, well, a couple of things. If somebody is having a regular problem, and I'm talking like every month almost build up something, then the ENT nurses are available and you could put a referral through. I think if you referred every single person to them, they wouldn't cope at all. And I'm not saying it should be used, but it is important to know that we do have the ENT nurses available for those patients that are having that real regular build-up, and that it would be inappropriate to continually ask them to access that privately. Obviously, anybody who has a known perforation, anybody who's had surgery on their outer ear, it's very important that you do refer them into ENT if they need wax removal. That is exactly what they're there for. And just a little bit of advice, really, if someone's a hearing aid user and they have an ear full of wax, the chances are just telling them to use drops is not going to be enough. Because how's the wax going to get out when they're wearing a hearing aid for 12 hours a day? So I know it sounds daft, but it does happen, and they end up with problems. So really just sort of be sensible maybe about who you're going, not who you're going to help, but about what the patient and how the patient's going to get the best help. I think in terms of referring, if you're going to refer and advise people to go privately, I would just be very conscious that earwax removal is completely unregulated. Anybody can go and do it. Anyone can go and set up. So if you are going to be advising, then it's just worth maybe directing patients or just, I would like to think it'd be better done by people who have an ENT audiology background, but that isn't always the case. So maybe just directing people and just asking them to be very careful about who they go to. Carefully wording that one. I wanted to touch on the sudden hearing loss. So as I say, Mr. Code has been doing a lot of work with primary care, so some of you will be aware of that. Up until only a few months ago, I would have said that the treatment of sudden hearing loss, there was only sort of a 72-hour window to be able to start the steroids. That has been massively extended now for up to a couple of months. That being said, if it was my hearing, I think it was your hearing, you would want that treatment to start straight away because it's definitely got a better chance of working. I actually know of 2 patients within the last 12 months who had a sudden hearing loss and contacted their primary care and were told, I'm sorry, there's no appointments today. And it's, it is a medical emergency. It needs to be treated as a medical emergency. And I would just ask that from leaving this talk, it's a conversation you have in-house that does your triaging service work. I know there's a lot of forms that come in and GPs do check, but maybe the person will just call through reception. So do they know to make sure that person is seen on that day? Common errors, shall we say, I see, or because we obviously get them for the rehab, myself and Debbie get them for the rehab after, especially when they've not had any treatment and they've not been able to recover any hearing. So common mistakes when we say to patients, what happened when you contacted? They said I had an earful of wax. Well, they maybe do have an earful of wax, but if someone has an earful of wax, they'll talk about muffled hearing. They'll say it feels blocked. They might feel the wax moving around. When people have sudden losses, it really does feel very numb and very dead. That's how they'll describe it. There's nothing at all, whereas wax is more of a muffled blockage. Another one is it might be congestion, so they get sent off with steroid spray for a couple of weeks. And again, you don't really get sudden onset middle ear effusion. It doesn't happen. That's more, the person would say, I've had a cold for a couple of weeks, I've just got over COVID, I've just had an upper respiratory tract. Fair enough, that's probably going to be middle ear, but it doesn't just come on that quickly. If you really aren't sure, if you're not confident, just put them into ENT. go through the on-call system that you have, get ENT to start talking to them. They will get them in within 24 hours, or if it was Saturday, they'll get me on the Monday. We'll get them in and we'll test them and we'll see what's going on. But like I said, I think if it was my hearing, I would want the opportunity to get those steroids to see if I could get my hearing back. So we need to make sure that we are actioning those cases quickly. So I just wanted to put the next slide in, which is just out of interest really, because it doesn't seem to be well known about, which is auditory processing disorder. Tends to be picked up when people will complain of hearing loss. They'll say, I think I'm losing my hearing. And actually they have a hearing test and it comes back as normal. You can have auditory processing disorder and a hearing loss as well, but you tend to get this picked up more often when they have normal thresholds. Generally it's associated where people, we get them as adults, but as a child, they had a lot of gluea. So when the neuroplasticity, it sort of changed filtration when the brain was being formed, when they were younger. So it seems to be linked in there. And the other thing, which I have no evidence for, but does seem to be true, and Sheffield do a lot of work with auditory processing, it also seems to be linked a little bit into minor head injuries. So where people like bump their head on a cabinet and they don't pass out, there's no big injury, and that seems to do something. Again, I can't give you scientific evidence, but there does seem to be that link as well there. Very limited formal testing. There's like 3 centres in the entire country, but within audiology, we can help them. We can give them advice. So we can talk about how they can help themselves, sometimes with using remote mic systems to improve signal to noise ratio. So again, I just thought opportunity to talk to you about these unusual disorders that you may see coming out on our letters. I did want to put on about sound sensitivity, not for too much, but just because there is a slight difference in management. So hyperacusis, we talk about people who will hear day-to-day sounds, but to them, they will be very, very loud and uncomfortable. Those patients tend to come under the main audiology service from a therapeutic management. We will do it through desensitization, the use of white noise, and potentially CBT if required. Now, misophonia is just very often known as not being able to stand hearing someone eat. So that tends to be the big common one you know about, and you tend to find these people will have a very fierce anger reaction to it, very rage-filled, not being able to stand those noises. Phonophobia tends to be when there's high anxiety around loud sounds. Now, those two patients, those two groups of patients tend to need more of a psychological approach. It's very much a psychological response they're having. And the reason I say that is because I'm not saying these people shouldn't come to us to have a hearing test and just to make sure there is nothing else going on. But it might be that we would bounce that referral back and say, actually, we think it's this, and we may be asking you to refer on to psychology. And that's why I just wanted to mention that. The other little thing that comes into sound sensitivity is recruitment, which is very much to do with hair cell damage inside the cochlea, where patients have reduced dynamic range, and that would very much be managed by us in audiology and their hearing aid provider, just to get the settings correct. Another important thing, which is really now, there's a couple of studies that came out sort of last year, and so it's really hopefully embedding now, and that is the strong link between hearing loss and dementia. There was actually a project presented at one of the conferences where they got a group of patients who had been approached the GP and said, oh, memory problems, and were starting to put on for testing. They tested them through the memory clinics, and then they took them off and tested their hearing and fitted them with hearing aids, and then they came back and actually they did far, far better on those tests, and actually their hearing loss was causing a significant amount of their communication problems. It's my suggestion, I can't say that this is a rule, but we would say from audiology that if you've got a patient who is coming in with suggestive memory problems, absolutely get the referral to go into those teams, but I'd probably suggest send them for a hearing test as well, because that will be helpful. And it's also much easier to test someone when they have, if they are going to end up with dementia and become very sort of challenging and difficult to test, the more tests we can get when they're better helps them long term. So I would suggest doing that. As if you're going to refer for memory testing, refer them for a hearing test as well. So that's been checked. Getting on to probably what you're all here for, which is referral tracks. We've got here about any qualified provider. Now, I think the any qualified provider scheme is very easy to understand, and it might be that the questions will come in about where you have difficulties. So the any qualified provider scheme has been around now in Derbyshire for probably a good 10 years in different formats. So we've had different providers jump on and off over the years. Now, a patient has to meet this criteria to be able to be referred to an any qualified provider. So, and I have a problem with this contract, I'll tell you why. So they have to be 18 and above. They have to have symmetrical age-related hearing loss. They have to be accepting of their hearing problems and they want to use hearing aids. And they can also have non-troublesome bilateral tinnitus, but it cannot be the primary concern. And the reason, and if anyone's on here from the big management who writes these contracts, I apologise, but this is why I have a problem with it. I don't know any 18-year-old that has an age-related hearing loss. I don't know a 25-year-old that has an age-related hearing loss. So I don't understand the contract. But you know what? They don't let me run the world, so I have to work with it. So I do struggle with this one. But I think that if you've got patients in front of you, you have to make that decision of, does it make sense that this person has a hearing loss? If it doesn't, you shouldn't be sending under the AQP scheme. You should be sending to us, as in both us and Chesterfield and Derby, who are the non-AQP managers for these unusual cases. Non-AQP, therefore, we will accept 16 and above. We want your unusual hearing losses, so those that are fluctuating, they are asymmetrical, that's going to come to us. Again, I've put in hearing concerns at a younger age, or young age, it should say. Those people that have an emotional reaction, maybe aren't accepting of problems and need more of a therapeutic response, that is us. Distressing tinnitus, unilateral tinnitus, pulsatile tinnitus. I've also put down here about learning disability and cognitive problems. Now, that's not to say that if the person meets the criteria for AQP and they have a very mild learning disability, they can go down the AQP route. That's not a problem. But I think the point is can they function in that clinic? If they require specialised testing, the providers for the special clinics for those with learning disabilities, those that have cognitive problems that would need a different test battery, that isn't AQP. That would need to come to us under the non-AQP scheme. So like I said, I think the AQP contract is easy to understand, but I do understand it has caused difficulties. So I'm hoping that makes a little bit more sense to you. What I've also put on here, I did this the other day, is a bit of a chart, and I don't know whether you did get slides or whether this would be helpful for you to have. And it was just really a list via age, because age is the big factor. So from people that you are referring 0 to 16, if you are referring just for a hearing loss, that's it. So not the tonsil and adenoids in young kids or these sleep apneas or anything like that. You refer them straight to children's audiology. There is no point sending these people, these little kids, into ENT. The medics don't want them until they know they've had their watch and wait, and then they're saying actually they want their grommets. They're much better going under children's audiology, who will do all the monitoring times. Again, it's the Den at Chesterfield, but they also have all the clinics in the High Peak. So you're still referring to Chesterfield, but they will go up there and see them. And of course, it's for Derby Children's Hospital service there. The 16 to 18-year-olds, just for hearing loss, you are going to refer to adult audiology, which is Chesterfield Royal, which is the High Peak. The way that Derby run all their referrals is they run everything under the ENT banner, and then John and his team go and pull the referrals out. So you can refer them under Derby ENT, but you may get letters back from audiology. From the ages of 18 to 55, and again, if they have age-related, think about that age-related word, if they have age-related bilateral symmetrical hearing loss with or without bilateral non-troublesome tinnitus, then you can refer them under AQP, so you can use any of the providers on screen. But the people who are 18 to 55 do need a GP referral to be able to access that. If a person is 55 and above, same rules, age-related bilateral loss, they can self-refer. So actually, again, you don't have to do any of that, and you could promote that, again, to your prescribers or your receptions. I don't know how you want to advertise, but those patients can self-refer. The bottom two boxes I could have gone on forever about, but your unilateral tinnitus, pulsatile tinnitus, distressing tinnitus, they, for both of us, again, come under the ENT referral and advice service. I've just separated these two things out because, yes, referral and advice service is under ENT, but they do have extra clinical codes that you could add. I cannot tell you how much it helps us out if you code it properly. So when it says ENT tinnitus, ENT dizzy, ENT nose, honestly, that smooths the pathway so much. So I've just separated them out so that you could see that. And again, I have included Buxton Cottage ENT for the high peak. It is who I sort of would suggest that you use up there in that area. What I've done, it was just to sort of show you what I meant by the clinical coding. So when you are choosing your referrals, this is Chesterfield, so we have audiology with them, ear, tinnitus, dizziness. So if you can put the correct code on the end, especially for the tinnitus, it speeds up that patient getting into the right clinic slot. It really does make a difference. So I would suggest you do that. Derby are just launching their new one, so I couldn't unfortunately get a copy. And Buxton ENT don't speak to me that often, so I wasn't able to get their codes either, but it is there, and I know that it would help them out as well, so you can use those. Awkward, really, depending on when I say this next thing. This is the 3 providers I would suggest you use for ENT. There are other providers, there are other little sort of referral pathways that have been set up for an ENT service out of various places over the county. These are the only ones I know of that have an audiologist working alongside them. If you are referring an ear patient, if they have a hearing loss, if they have tinnitus, if they have balance problems, they are going to need a hearing test to have a completed pathway. And these other ones that have been set up don't have audiology as part of their service. So I would suggest that you by all means use them for the noses and throats, fill your boots, send them all that way. But in terms of your ear patients that need audiology and need a hearing test, these are the ones that we're aware of, and these are the ones that do have a complete loop pathway because it's all built into our services. So that would be our suggestion, and it certainly makes our lives easier. Little slide here on tinnitus. Again, this is the one where when I started to write it, I could have gone on until midnight. I have plenty to say, and if you'd like to know more, and we're always happy to do a little bit more on it. There is tinnitus and tinnitus disorder. There are plenty of people out there that have tinnitus, which is not a concern, versus people that have tinnitus disorder who are just sort of distressed by it. Obviously, we have our subjective tinnitus and objective tinnitus. It is most likely the 2 causes that we find in clinic would be a link into a change in hearing threshold. So if their hearing has declined a little bit, the brain will backfill and put tinnitus in to try and fill the gap, or it will be a trigger from a stressful life event. Which is why every patient with tinnitus must have a hearing test, which is me going back to you need to send them to an ENT service that have a hearing test as part of the pathway. I would ask you to try and use positive language. I would say that this has improved in all my years of doing it. We do get less negative words coming out, but the things that sometimes when we always ask every patient, what did your GP say to you? What did the nurse say to you? And it does happen where they'll go, well, they told me there's nothing can be done about it. Tinnitus itself can be highly stressful and distressing to those patients. And obviously anything like that feeds into that negativity. So, you know, I appreciate that you might not be able to do much in primary care, but what you can do is tell them that we can help them, that you are referring them on to people who are able to offer support, that there is help available, and that it's very rare that we can't make it better, whether it be things that we can do or we can guide the patient to help themselves. But we would just ask you to consider the positive language and to make sure that patient leaves your clinic feeling empowered and that they are going to get the support. If you would like to sort of provide some information, then the British Tinnitus Association has a fantastic website, and they've just literally rebranded as Tinnitus UK. So we're all getting used to those new words, but it was the British Tinnitus Association. And we're also quite lucky to have 2 support groups in the area. So we have Chesterfield and North Tinnitus Support Group, and Sarah a couple of years ago started one for Central Derby and the South, and the contact details are there. And if you want any more information, or you want some of their leaflets or anything like that, we can always provide that, or get them to provide it for you if that would help you. In terms of scanning in primary care, not particularly saying you can't scan, but if you want to scan, then just scan the correct things. So if it is unilateral subjective tinnitus, we want MRI IAM, that would be the scan. Now, pulsatile tinnitus, up until today, my note said if you don't have to, scans are built into our pathway, so you don't have to scan anybody in primary care. We will scan them when they come through after we've done our assessments and done the hearing test, and we know what they need. Up until today, my slide here said if you want to scan for pulsatile tinnitus, then the scan that you need is CT scan, high-res CT scan, temporal bone, and you need to make sure it says pulsatile tinnitus, and radiology have a test battery. I've literally today, we were talking about it, we've had radiology reject 2 referrals from GPs, and they said, no, you need the person needs to go to ENT first. I would kind of agree with that with pulsatile tinnitus, because it could be caused by a middle ear infection, and we don't need to be scanning people without a need. So yeah, up until this morning, I was going to tell you should send for a CT scan if you wanted to, but now if it's pulsatile, if it's objective, I would, I don't think radiology would accept a request for the scan anyway, so you just need to get them on to the tinnitus referral system. The last bit of the slide is to talk about vertigo. Again, another thing which really could have gone on for hours and hours, and maybe that will be a separate talk one day. Positional vertigo, obviously very, very common, the most common cause of balance disorders present in primary care, and can be managed if you're confident doing it with the Epley manoeuvre. What has concerned us in the last few years is the increase of printed sheets given to patients telling them, please go and do the Epley yourself. I don't think that is the best idea, and we would ask you, I'm going to blame Debbie as well, we would ask you to not do that. It's not very safe for patients to try and do the Epley themselves. If you don't feel confident doing the Dix-Hallpike and the Epley manoeuvre, that's fine. I'm not asking you to do it if you're not sure, but there are some exercises called Brandt-Daroff. You could give those out. They will be a lot safer for those patients, but I really don't think it's a good idea asking patients to do home Epleys. Balance rehabilitation. It's not that we're asking you to do a balance rehabilitation program in primary care, and I really do want those referrals to come in to us and get them through ENT, and we'll check them out. But there's a very, very strong overlap for people who end up with chronic dizziness when their anxiety and stress is very high. So what I would ask you to do is to think about the patient's stress levels. Yes, you need to manage them, but also sort of promote relaxation and try and promote the person to sort of move as much as possible, because those ones that end up with chronic vertigo have generally ended up with back and neck problems because they daren't move and they're very fearful. So yes, I would just from the primary care level is getting them treated, obviously getting the referrals in if it's something that's not manageable in primary care, but again trying to promote as much positivity and relaxation and getting the person to work on stress levels and to really try and keep moving as much as possible, even before they've had a diagnosis, absolutely, because that will hopefully prevent some of this chronic dizziness by the time they've got that R waiting list and things like that. I've just realised very, very quickly that I forgot something on the last slide, which is on tinnitus, which is NICE guidance has now it did it in 2020, but it got lost in the COVID bubble, has absolutely ruled out beta-histine as a treatment for tinnitus. So you shouldn't be prescribing beta-histine for somebody who is there, who's just got tinnitus. Obviously, very, very useful for your many years patients. I'm not saying that, but as tinnitus as a standalone, shouldn't be prescribing beta-histine. It has been ruled out as a useful treatment, and doesn't work. So that is the end of the slides, and I'm hoping someone else has been watching if there is questions, and now I've got to work out how to get out of it.
Do you want to introduce yourselves, everybody? Did you want to say hello?
Yes, I think they should.
Well, I'll go first then. My name's Debbie Alvey. I work very closely with Jodie at Chesterfield Royal. I have been trying to answer very quickly at the same time as listen to Jodie. So if I've made spelling mistakes, I'm sorry. But yeah, if we can branch out on any of those things that we've popped down there.
Hi, so my name's Deb Farr. I'm the Audiology Service Manager for North Derbyshire. As Deb says, we've been trying to answer some. I did leave the question about the over 55s referral for AQP, because John, you refer some patients yourself, because we don't actually refer patients for AQP because we are an AQP service. But certainly as far as I'm concerned, the AQP contract says that adults between 18 and 55 can be referred, but they have to have a referral from primary care. They can't self-refer. But it has to be for an age-related hearing loss that's bilateral. So although you could refer an 18-year-old, you would question why an 18-year-old has got an age-related bilateral hearing loss. So therefore, you're not going to refer an 18-year-old on that pathway. Yes, if you're probably going to think about your 40-plussers, depending on what they say and how they say it. So that pathway should be there, but it's by referral from you guys, so you can vet which pathway you think is the most appropriate for that person at that time.
Yeah, hi everybody, my name's Jonathan Butler. I'm head of the Adult Audiology Service on the Derby half of UNHDB. As Deb's just said, as far as I'm aware, the AQP contract is a county-wide contract. There is no separation of criteria between the north and the south. So yes, there is self-referral for over 55s, but primary care referral for those between 18 and 55. As has been talked about before, we are not an AQP provider in the south of the county.
That's brilliant. Thank you so much. And lovely to meet you all, Debbie, Deb and John. If we just go through a few bits, as you say, you've answered that one brilliantly. Rebecca had asked about doctors talking about dizziness and whether that could be due to earwax. And I think, Debbie, did you answer that lower down about saying?
Yes, it can if it's really impacted. I think they tend to say that they feel more woozy than spinning. Spinning doesn't really very often go with wax. So I would say, you just need to get them referred if they're feeling dizzy. We need to have a look at them, get wax taken out, and then see what goes on after that.
You see, if both myself and Debbie have an issue with the word dizzy, because it actually doesn't tell you anything at all. So it's the one thing that we're always keen to go against. What does dizzy mean? It doesn't actually mean anything, or it means so many different things to different people. So yeah, I think in terms of the question would be, does earwax cause vertigo? And the answer is no, not that I'm aware of, unless that wax is hiding some horrendous middle ear infection or something, where yes, that would. But wax in itself is not going to give the person true vertigo. If they're blocked on one side, they might feel disorientated because they're off balance in that way, but I wouldn't expect it to give true vertigo. So.
Yeah, that's what I thought, but we did actually have a case where I think a locum had gone, oh, you're dizzy because of the wax, and it turned out to have stroke. So it is one of those things that we do need to be really careful about. And
I think they're the cases again where if you not that you thought it would be causing that, but if there was so much complexity, that's a perfect case to go into the ENT nurses, you know, there. But just, I would just say, make sure your letter is clear if you are just referring for wax removal, because if you put it through and it goes through a normal path, it'll just sit on the doctor pathway. Myself and Deb, we literally go through every single ENT referral. I think John does the same for Derby. We go through every single ENT referral, and if I see any that says I am just referring for microsuction, we whip it out and we put it on the nurse's clinic, which is very, very quick. But if you don't make it clear, it's going to fall into the doctor pathway, and that will be a lot longer. So just make sure you're very clear on what you're referring for.
That's good to know. Thank you.
Yeah, that's really useful advice. That's not a case that you forget, is it, Rebecca? Janet had just mentioned a case that she's about a child, but she'd had some moderate hearing loss after using an app, ongoing hearing loss. They tried olive oil drops, and when Janet had looked at the ears, they were full of wax. Would that be suitable for an ENT referral? And Deb had said basically yes, hadn't you? Yeah. Yeah, great. So I'll just go further down. Yeah, so that was the dizziness. And then Machine had asked, and again I think this is responded to, in sudden hearing loss, what differential diagnosis are we considering that would respond to steroids? I think the Debbie, you'd said usually vascular.
Yeah, so if it's viral, it doesn't tend to be as responsive, but there's no way of usually telling the difference, which is why we really keenly want to get them all in, to have those tests done and to hopefully get that treatment started and tried. And again, now because there's a new study and because of what they're doing, they've increased how long they'll give the oral steroids, and they are now injecting pretty much straight away into tympanic within days, which is why it's really important. The triaging system works. If they're contacting primary care, then I have an issue with them going to the emergency department, because they seem to, I'm trying to work on that as well now, because they seem to keep missing them as well, but that's a different argument. So, if you get the contact in primary care, pick up the phone, bleep the on-call into the local hospital, speak to them, and we've got a plan. We'll put them in. They'll get them into clinic straight away. So
Jamie, I'd seen someone with a history that was suggestive of sudden, the patient was describing sudden hearing loss, and I called ENT and they said, give them some oral steroids and we'll see them in 3-4 days.
Yeah.
So is that a reasonable time frame? Because I did say, obviously the guidelines say 24 hours, and they're like, well, we can't.
So it used to be 72 hours, and that was it for oral steroids. Now they've increased that up to about 3 months, which is why, again, it's but even if it's that, you don't want that person coming from a routine referral or even you don't want an urgent paper referral, because it just, Deb, we're laughing, but every referral I see is marked as urgent for everything. So that's why nothing gets through as urgent, because everything's marked as urgent. So if it's something like that, pick up the phone and have a conversation with the on-call team, and they will put them in. Don't do a paper referral for anything.
Lovely. Well, thank you so much for answering so many questions. I think everyone's really enjoyed that. So thank you all of you for joining. So thank you so much, Jodie, for talking, but also Deb and John for coming along as well. That's been invaluable.